Hello, my name is Alan Pitt. I'm a physician at the Barrow Institute in Phoenix, Arizona. In addition to my clinical work, I spend a lot of time thinking about clouds and crowds, how we can help one another through simple devices like laptops and PDAs and deliver the right care at the right time. Although we would like to think that all care in America is equal, it's not the case. Where you live has a significant impact on how you're treated. However, I would suggest existing partnerships may be able to address some of these inequities. Stroke in rural America is treated differently than in the cities. It's not that the drugs aren't available, or that the providers are either uninformed or more often uncomfortable with best practice. The result is patient outcomes, your outcome, if you're in the wrong place, is worse. We can make the best drugs in the world, but it really doesn't matter if patients don't get access to them. If your physician isn't comfortable with newer medications, you're not going to get them on time. In part, this is perceived liability. Many rural providers simply don't give TPA with any frequency to feel comfortable with administration. One can extend this to less acute scenarios. In the case of cancer, travel to and from centers of excellence can become a barrier. Imagine you're 45 and have a new diagnosis of breast cancer. Are you going to be able to juggle your home, work, and hours of travel, often multiple times a week? As a result, the option to go to the tertiary center may not even be suggested to you by your local physician. All in all, not good. So what's the solution? Well, telemedicine, the ability to bring people together over video, has been suggested as an alternative. In the case of stroke, studies have shown that active participation via telemedicine from centers of excellence increases the administration of TPA and actually dramatically reduces the rate of transfer from rural to tertiary centers. However, to date, the technology has often been seen as too expensive and without clear reimbursement for care providers. A visit in person is viewed as different than a conversation on the internet by many payers. Newer technologies allow any device, any network to provide care. This means two physicians or care providers can meet in time to administer clot-busting agents, or that a patient can travel to a tertiary center for surgery or radiation only, but get their daily chemotherapy 20 minutes away in their hometown rather than 5 hours away at the Center of Excellence. So with telemedicine, or what I prefer to call collaborative care, the patient care comes to the patient rather than the other way around. Clot-busting agents are administered in time, and the patient travels for exotic surgeries or possible radiation to the Center of Excellence, but chemotherapy can be administered down the street, with providers from the city monitoring labs, checking on imaging, and seeing the patient, assisting local doctors and nurses in the care of the cancer. So who's really incentivized to offer these solutions? Well, clearly, the patient and their family benefit. Local providers, both physicians and hospitals, also win. They transfer the patient that needs to be treated in the city, but keep more patients locally for revenue-generating procedures such as imaging and infusion. The payer wins. Better care often means less complication, less utilization, and a differentiator in the marketplace. So, for instance, your insurer may offer you the opportunity to see someone remotely rather than have you travel. Travel less, rest more. But what about industry, the device and drug manufacturers? Ironically, they also have something to gain. By extending expertise to the patient rather than limiting it to the city, more patients are likely to get access to correctly administered life-saving interventions. Of course, it doesn't hurt that this speaks to the bottom line. Industry is already spending millions of dollars trying to get these therapies out into the marketplace. This just accelerates that. Concerns from industry typically revolve around liability and exclusivity. I'm not suggesting that industry undertake either of these, but rather as one travels about and educates rural providers about different drugs and devices, that they can educate these providers on solutions rather than simply treatments. Talking to rural America will meet with resistance about these new drugs and devices until they realize they're not alone. The world has changed. We can deliver the right person in time over any device, PDA or laptop, allowing better care at a lower cost. Thank you.